Hello everyone, I'm Zilu from the Rang Shao Hospital, and I will give a presentation about my meta-analysis comparing anatomic versus non-anatomic resection for hepatocellular carcinoma. This presentation will include 5 parts: the background of this analysis, methods we used, the results, discussion, and the conclusion. Hepatocellular carcinoma is one of the most common primary malignancies and the fourth major cause of cancer-related mortality in the world. As we know, hepatectomy is one of the main treatments for HCC, and the impact of anatomic versus non-anatomic resection is still debated. However, the most recent meta-analysis of this topic merely included studies up to 2018, and the baseline characteristics of AR and NAR groups were usually inconsistent with large heterogeneity in most of the studies. Therefore, we performed this analysis using updated data to compare AR with NAR in terms of prognosis and perioperative outcomes in HCC. This meta-analysis was implemented following the PRISMA guidelines. PubMed, EM-based Web of Science, and Cochrane Library were used to search related studies published in the past decade. We included randomized control trials and propensity score match studies to avoid heterogeneity. Primary outcomes were overall survival and recurrence-free survival, and secondary outcomes were perioperative characteristics such as operation time, blood loss, and so on. Besides, subgroup analysis was conducted based on the presence of microvascular invasion. All statistical analyses were performed using Stata software version 12. As shown in this flowchart, a total of 533 studies were retrieved, 219 of which were screened after removing the duplications. We read the full text of 37 manuscripts, and finally, as shown here, 13 studies with 3,537 patients were included in our meta-analysis. One was RCT, and the others were PSM studies. Most of the studies were from East Asia. As we can see, most of the baseline characteristics were similar between the two groups, such as age, gender, hepatitis, and so on. The primary outcomes of this meta-analysis were OS and RFS. There were no significant difference between AR and NAR in OS, but it's obvious that AR is associated with superior RFS, although there were no significance in 1-year outcome. The secondary outcomes were perioperative characteristics. As shown in this figure, blood loss in AR was significantly more and the hospital stay was longer. We also performed cumulative meta-analysis to review the ongoing trend of the benefits between the two procedures. Generally, as we can see, AR is achieving more benefits than NAR. Particularly, the benefits of AR in 3-year and 5-year RFS had become significant since 2018, and a switch to favor AR in 5-year OS was shown in 2017. This may attribute to the advance of surgical techniques. A total of 7 included studies reported the survival outcomes of patients with and without MVI. Therefore, we extracted the hazard ratio of OS and RFS in the case of MVI positive and negative patients separately for subgroup analysis. Interestingly, in patients with MVI, AR was associated with better RFS, while in patients without MVI, AR achieved prior OS. However, if the standard of significance is increased from 0.05 to 0.1, the priority of AR is significant both in overall and recurrence-free survival here. To the best of our knowledge, this is the first meta-analysis that reported the benefits of AR both in patients with and without MVI. Finally, we'll identify the potential bias in our meta-analysis. As shown here, these funnel plots demonstrated a symmetric distribution of all the included studies, and no potential publication bias was discovered by Hubbard, Peters, and Eager tests. Our meta-analysis revealed that AR is associated with better 3-year and 5-year RFS, while the OS and 1-year RFS remain similar. Generally, AR is considered a radical procedure and may result in insufficient liver function and even patient's death. This may explain why AR failed to gain a better overall survival. In patients with MVI, the results suggested that AR can achieve better RFS, while the OS remained the same. This is acceptable because AR resected the whole segment with MVI, thus blocking the spread of existent invasion more efficiently. However, the inferior liver condition of MVI-positive patients caused their vulnerability to resection. Therefore, it's expected that AR showed superiority in the MVI-negative group, whose baseline liver function was better for survival. Furthermore, the risk of recurrence is intrinsically lower in MVI-negative patients, which weaken the difference of the two groups in RFS. One limitation is that MVI can only be confirmed through intraoperative frozen section or postoperative pathological analysis, thus limiting its guiding value. However, AR is still recommended if the preoperative examination indicates the possibility of MVI. Recently, there were several articles reporting the advanced approach to accurately predict MVI from MRI or CT images. Combined with the advanced predicting techniques, our finding can guide patients to choose a more favorable surgical procedure. In conclusion, this meta-analysis revealed that AR was associated with better recurrence control, even the blood loss and hospital stay were unfavorable. Interestingly, our study revealed that AR can lead to a better prognosis both in patients with and without MVI. The advance of surgical techniques has made AR preferable for HCC patients, and this may finally end the ongoing debate between AR and NAR. That's all for my presentation. Thank you for considerations. If you have any questions, please don't hesitate to ask me on the discussion board. Thank you.